This year, the Hypertrophic Cardiomyopathy Association marks 30 years of connecting patients to expert care. During that time, HCMA has recognized more than 60 centers of excellence across the United States. These programs use a multidisciplinary team approach to help you manage life with HCM with access to the latest diagnostics and treatments. One patient says his center helped him finally feel heard and confident in his care. To learn more, visit the HCMA website and use the Centers of Excellence directory to find the right program for you and your family. This season, Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association, takes a closer look at America's healthcare system. In this special series, we explore how today's system was built, why it's falling short for so many, and where care still misses the mark. This isn't about politics or blame. It's an honest conversation about how healthcare works, where the money goes, and what needs to change while recognizing what's working and saving lives. The system is strained, and it's time to talk about it. Here's host Lisa Salberg with Deconstructing Health Care.
Good morning, everybody. It is January 16th. Happy birthday, Sandy. It is 11 a.m. on the East Coast of the United States. This is Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. I am your host, Lisa Salberg. And in this edition of Tales from the Heart, we are going to be talking about Deconstructing Health Care, which is a series we're going to be bringing you throughout the year for a conversation about the basis of healthcare in the United States. Where did it come from? How did it evolve to where it is today? And building a good foundational understanding of the U.S. health system that we are now required to interact with for our personal health care. I will be bringing on a number of guests to help us understand the foundational aspect of healthcare in the United States, and they come from a great degrees of different backgrounds. And today I have joining me Jan Berger, who among other titles is author, and one of her books is Re-Engaging in Trust, the Missing Ingredient to Fixing Healthcare. So she's given it some thought, and I'm going to ask her to tell you a little bit about her background, and then I'm going to tell you a little bit about things about me that you may not know about my relationship with the healthcare industry. Jan, thanks for being on Tales from the Heart. And I should mention, for full disclosure, Jan is a member of the board of directors of the Hypertrophic Cardiomyopathy Association. So Jan, thanks for joining us. Thanks for your commitment to HCMA. And why don't you tell our listeners a little bit about who you are?
I'd be happy to, Lisa. Thank you for inviting me. First of all, besides being on the board of HCMA 2 years ago, I was diagnosed with HCM. Which added in my profile, which you'll hear in a minute, the title of patient. And so I am living through everything you all watching this or listening to this go through. I'm going through with you. Along with that, I am a pediatrician by training. But did leave the active clinical practice of medicine almost 30 years ago. I've been a senior executive in a health plan. I have been a senior executive in a PBM. I have been in government, and you'll hear whether it's today or in future conversations. I was involved in both Medicare Part D and the Affordable Care Act. And I have consulted with healthcare companies around the world. So I have a very broad base of knowledge. And interesting when I talk about, I want to point this out because I think it's very important. I have been involved in both Democratic and Republican aspects of healthcare. So my comments are not tied to a political belief. but into what healthcare is today, what it was yesterday, if you will, and what it will be tomorrow, that can help all sectors of healthcare. I really, as Lisa asked me to get involved in this, I said, understanding the past and where we came from and the foundation of healthcare, it's kind of like our family history. You need to know where you came from in order to understand where we are today and why things are as crazy as they are, and maybe what we can do to fix it in the future. So, Lisa, I'm going to hand it back to you.
Jan, thank you so much. So our listeners can understand why I would have wanted to talk to you about this. But many of you are just coming to know the HCMA maybe in the past 5, 10, even 15 years. You just think that I've been doing this my whole life. Before I gave up the day job to run a nonprofit organization, I was in the human resource sector, and I worked in health plan administration. So in 1988, I was coming into this new job. They were insured by Blue Cross Blue Shield of New Jersey at the time, and the premiums were going up 33% a quarter. We were just getting these increases, no additional services, in fact, reduction of services, but premiums were going up. And I looked for alternative methods to insure this group. And at that time, we did something that was predominantly for large employers or unions. We became self-insured. So we went through an entire maze of, I wrote an entire plan for our company. We had stop loss insurance. I bought into a network. We had early PBM and Express Script. So I pieced together an entire program, and I ran that program for 18 years while I was in human resources. I left in 2005. They did not maintain that system after I left because it took a bit of work and knowledge to know how all the pieces fit together. And they went to traditional insurance, and my former staff members at that job would call me in my new job and say, can you get our insurance back? Because we really liked what we had before. So I came from that background of building a health plan and administering it to being on the other side of patient advocacy, trying to help other people navigate through whatever health system that they had access to. So that is what we're coming to foundationally. And as I thought yesterday, Jan, on some of the slides that we're going to be showing today and starting to walk through the history of healthcare so people understand what is foundational, something dawned on me that is beneath the foundation of what we built here in this slide deck. And this is going to be a growing slide deck through this series. The U.S. is a country that is a basis in law, and our laws are what everything else is built upon. So when a law is passed that we're going to do healthcare a certain way, this tends to be a federal law that we are basing the foundation on, and we are building upon federal law. So we need to have a base understanding that this is a legal process, that we've developed a health system in this country, and that is where we start with that action of Congress, that act of law. So we start there and then we build. So Jan, let's take a look at our next slide here, which I'm gonna get there we go. We're going to start at post-World War II United States. Can you bring us back in time a little bit, Jan, and talk about where we were then and what was happening with healthcare in the United States?
I'd be happy to. So we had just coming out of World War II, and interesting, inflation in the United States was very, very high. And what we saw happen was that the government, as Lisa just said, put limits on what employers could pay their employees. So there were wage freezes, and that made it very difficult for employers to get new employees because you couldn't differentiate yourself from other companies through what you were paying them. And so we saw the onset of employer insurance, because what happened is they started to be able to offer health insurance as a differentiator. And it didn't happen overnight. One or two companies did it. They saw that they could make a difference in the market in who they got as employees, and it gained. So that was one thing. Along with that law of wage control was the IRS in 1954. Again, legal, Lisa. I love the fact that you thought of it this way, because it really does explain people do things for reasons. We don't always understand the reasons. We don't always agree with the reasons, but there are reasons. The IRS made employer health benefits tax exempt for both the employer and the employee. That was a second impetus for employers saying, I'm going to give you this if you come join my company. And by the way, internally, I have to pay for that, but these are tax differentiated things for us. And that was for the employer and the employee. What happened, the so what, was we went from only 9% of people having health insurance from their employer to, in 1960, almost half the country had some form of health insurance. But again, I want to remind us, interestingly, the health insurance at that time was major medical. What does that sound? What does that really mean? It was only what we would call catastrophic, your heart attack, you were hit by a car, things of that nature, preventative care, vaccines, medications, going to see your doc because you've got cold and flu season, which we're seeing is horrible this year. None of those things were covered. So think of it as your car insurance, where your insurance doesn't pay for you to go get your oil changed or any other things that can happen. It's if you have a major crash. And so that really, in this time frame, we went from paying for everything by ourselves for health insurance to having some form of insurance for about half the country.
Okay. So this is a change, and this is where the term benefits starts to come in. They were giving fringe benefits with your employment contract or your employment arrangement. And this is where you'll now we just call them benefits, but that's where the term came from. And it was that differentiator. And there were a lot of unions involved with this movement to make sure that their members had good coverage. So a lot of union negotiations included what kind of healthcare services were going to be available to their staffs. So then we move a little bit forward in time. Oh, wrong place.
Hey, Lisa, let's take one more step, because you have a bullet point in here that's also very important as we build on this. And that is the physician autonomy. Okay? Because at that time, any of us, I was alive in that time. Any of us who were alive in 1960, the relationship you had with your doctor was 100% between you and your doctor. There were no outside entities that said, you can have this, you can't have this, because most things were still being paid by you, the patient. Okay? If I got sick as a kid, my mother took me to the doctor because we had some level of health insurance, but we still paid most of that bill to the doctor and anything that went on. So the physicians had autonomy. And interestingly, physicians didn't have the national guidelines. And we're going to talk about national guidelines in a minute because it affects us today. And how we're treated and what is covered. In those days, there was no physician national guidelines to go by. A physician learned from the physicians they trained under. It was kind of like any of the other trades. Plumbers, I hate to say it, but we were no different in our training from plumbers and electricians and other individuals in that world. So who taught you is kind of how you treated your patients. There was no augmentation or integration of what's good science at that time.
So we were dealing with doctors' autonomy. If they needed to do a procedure, if they needed to prescribe something, that was between the doctor and the patient. And typically, I can remember my parents in the late 60s, early 70s, going to the doctor, writing a check, and my mother at the end of the year would send all of her receipts into the insurance company. And if they covered some things, they covered some things, but our typical out-of-pockets were not covered. And then they would get a tax write-off at the end of the year for doctor's expenses back in that day. My mother was the bookkeeper for the business in the house. So I can remember her submitting those back in the day. I do want to go back in time a little bit to think about what Truman attempted to do and his failed vision, which was very aspirational as to what he was hoping to do. But let's talk about what he wanted to do, and let's talk about some of the factors that might have been involved with that not being able to come to reality. You want to touch on that, Jan?
Sure. So Truman was really looking for a national health insurance model where everybody was covered. And there was opposition from everybody, okay? So he had a wonderful model, and most of the country didn't agree with him in Congress, okay? And interestingly, many individuals who weren't in Congress didn't agree with him. So the medical societies didn't agree with him, employers didn't agree with them, patients were worried that this would get in the way of the relationship. So his model, which was very visionary and really would have changed our healthcare system to look much more like the European healthcare system, failed. But, and we're going to get in the next slide to what this led to. So he had great vision, tried, didn't work. What did work, Lisa, is on the next slide.
We have to get to 1965, which, by the way, doesn't just nothing doesn't happen between 1945 and 1965. We were going through processes. We were having conversations. There were hearings. There were committees. There were discussions on how we as a nation were going to build a health system. So you want to talk about the significance of the Social Security amendments of 65?
So 1965, and this is we just finished an anniversary year for Medicare and Medicaid. But why did this happen? Well, what we found was that Lyndon Johnson realized, because Lyndon Johnson actually was pro the Truman vision, but he realized that, and Congress realized that they could start to put their finger on the scale a little bit and address the issue of health insurance for the country by starting with seniors. They figured it was a very controlled group of individuals. If you look back to 1965, most people who were seniors, who were Medicare eligible, only lived a few years. And the treatments were very controlled. Very different healthcare environment than today, where people live 20, 30 years on Medicare, God willing, knock, knock, as a Medicare member. So they thought that the theory was that we'll start with Medicare, and slowly, as people get used to this, we can expand to eventually getting back to the Truman vision of total health care coverage for everybody in the country. As we know, that has never happened. This argument continues to today when we hear conversations about Medicare for all and things of that nature. Along with Medicare, we had a very, very small, again, controlled group, And Medicaid really started as, we'll take care of the children and we'll take care of the seniors. Because who can argue about my child or my grandmother? So they really were going to sandwich it and then slowly bring it all together. Unfortunately, that slowly bringing it all together is still something we are challenged with today. But we have to again remember, it wasn't just in those days, you didn't have many vaccines. You were just starting with vaccines. You were just starting with medications. So care for children was really infectious disease. That's all they were looking at. And they figured it doesn't have to be all children. It'll just be children of a certain socioeconomic level who really need the extra help, and then seniors. And again, very limited on what the care was. It was catastrophic care. It was end-of-life care. It, again, was not preventative care nor medications.
72 comes around and there's some expansions for more disabled individuals.
Correct.
So we see that the safety net wasn't good enough just for young and old, but the disabled had to get some coverage here. So that expanded. And again, trying to narrow the gap for all, but again, picking and choosing what disabilities and how that was defined. And it's still a challenge today. Yeah. So we've gone through Truman and Johnson, nobody that's been elected recently. So again, as we're having this conversation, we're being very specific to bring in the individual people that were in power at the time that these things were signed in. But you're going to see that these are Democrats and Republicans. So we're not talking one party's vision versus another party's vision. This is about the fact that we all need health care. So there's some messaging coming through here that I hope you're hearing, that as a country, we decided that this is where we were going to go and these things were voted in. And here we are in 1972. But there's some other stuff that's going on around this time as well. So Nixon plays a big role here. And some of it's good and some of it leads to places I don't think anybody ever could have intended. So, Jen, you want to talk about the HMO Act of 73 and the Kaiser conversation with Nixon?
Yeah. So, interestingly, a number of things happened with the HMO Act of 1973. You know, so many people attach themselves to the term HMO. And, you know, there's a great picture that I use in many talks that was on Time magazine of somebody doing the scream. What's the screamer? Sorry for my facial there, but you know what I'm talking about.
You know, Edvard's screamer.
Yes. Yes. But the truth is that some really good things came out of the HMO Act of 1973. Health maintenance organizations, which is HMOs, we forget what those letters mean, promoted actually wellness and prevention. It was the first time health insurance went, or was supposed to go, from sick care to well care. And so that was number one. Number two was, it was the first time we started to see organized medicine. So for any of you who watched old, I'm showing my age here, Dr. Welby and all those doctors. I wanted to be Dr. Welby. That's why I went into medicine and when I went into pediatrics. For so many reasons, I didn't end up as Dr. Welby. But the truth is, you started to form groups of doctors. What used to be one or two doctors working together with their nurses, and in some cases not nurses, but just the doctor. The first time I did moonlighting was with an individual doctor in the late 70s. And that was the practice. And they'd bring in young people to help when they'd go on vacation or get sick. So you went from promoting wellness and our whether it's well child checks or us going once a year to see a doctor or whatever, and from, only going when you're really sick and really, really sick because you were paying for it out of your pocket, to this wellness model. You went from individuals to groups. You also, this was the first time you started to see for-profit medicine. And this was part of the agreements that Nixon made. Nixon made several agreements, the same way Lyndon Johnson made several agreements during Medicare and Medicaid. So where Johnson made agreements with organized medicine, so did Nixon. And so you start to see the greater growth of Blue Cross Blue Shield and these other insurance companies. But it really laid the groundwork from nonprofit to for-profit. Doesn't necessarily mean publicly traded, and we can go through all of that at some other follow the dollar. I don't think that goes into
coming up. Follow the dollars are coming. Yeah.
But it goes from nonprofit to for-profit. I will tell you, interestingly, personally, in 1984, when I started to practice medicine after I was out of medical school and residency, I went to work for an HMO in Chicago. And it was a staff model HMO, and there are different group types of HMOs, but it was run by the doctors. It was run. That's how I got into administration. And so the doctors really decided that. The second thing that happened was the advent of national guidelines. And we're going to talk about that in a minute. But you really started to see wellness, you started to see groups coming together, and you started to see national guidelines and quality to come into the picture. Those are the good things. Some of the bad things are what come out of the cost of healthcare and how to control how HMOs started to control how we got care, what we paid for care, things like that. You didn't have to do that before because most of it was we were paying for it out of our pockets. Now with the HMOs, others were paying for it. And so they had to start to control cost.
So you have premiums that we're paying in, and I can remember the old HMO models where you go, you pay $5 at the doctor, you get everything done. You pay $10, you get everything done. And it was very controlled HMO, but that didn't last for very long. We'll talk about that in a moment. Jean will address your question or comment in a moment here. So we get, Nixon makes the shift. The Kaiser tapes, if anybody has an interest in looking at archival data here, they're really interesting to listen to because we know Nixon taped everything in his office. And the conversations with he and the Kaiser brothers are documented. You can go pull those from a number of different sources online. I'll see if I can link them here at some point. But it really is this aha moment of a different method of healthcare. Mm-hmm. And I think there was a lot of promise in that conversation. But once things shifted in other ways, the wheels started to shake a little bit on the system. So for this podcast, for this episode, this is as far as we're going to take this is our last slide that we're going to show today, because this is a lot of law. Remember, we started off of the fact that everything is based on the laws. So 73, 74, there's some changes. We kind of ride through the rest of the 70s without major legislation. Then we hit the 80s. So tell us what happens in the early 80s, Jan.
So several things happen in the early 80s. And in many of these, we will go in, Lisa, in subsequent webcasts, we'll go through them in more depth. But in 1984, there was a thing called the Hatch-Waxman Act. Okay, basically it was the Drug Price Competition Act, if you will. Why does this matter? I'm not going to go in, lots of things that went into it. But the truth is the Hatch-Waxman Act, because it started to help control medication costs. Before that, there were very, very few medications on the market, guys. And many of them had been around quite a while. But it started to control prices, and actually it is the birth of generics. And once generics came into play, if you follow the dots, health insurance started to cover drugs. Before that, basically drugs were not covered. For all intents and purposes, unless you were in the hospital, drugs were not covered. So that becomes very important, as many of us, most of us with HCM are on one or many drugs. I went from 0 drugs at my diagnosis to being on 7 drugs now. Okay? So big deal there. Number 2 was we started out by talking about the advent of employer health insurance. Well, we started to see people go from having one job for their whole life or working for one company for their whole life and having insurance that way to starting to switch jobs. And so the whole job market changed. And so what happens when you're in between jobs or lose your job or change jobs? You needed a safety net. And in 1985, we started to see COBRA come into play, and the COBRA Act was put in. And that allowed you to have a safety net for a period of time, not the rest of your life, but for a period of time in between being covered by jobs. So that became very important in order to address that past issue of employer health insurance.
So let's just talk about COBRA a little bit more. I spent a lot of time here. This is when I started to enter HR, was like around 85, 86. So this is exactly when I show up into the healthcare field, we start talking about COBRA. It allows an employee 18 months of coverage. They pay it themselves. If the employee dies and there's a spouse that was covered, it gives them, I think, 36 months on the plan. Or if somebody becomes disabled, there could be an extension for disability. But you're paying the full freight premium plus 2% administration fee. So it's not cheap, and most people couldn't afford it. And I know I played the COBRA bridge game many times because you had to elect coverage within a certain period of time, but then you had so much time to pay for it. Sometimes you'd get your 60 days and your next policy would be in place. So you're juggling plans and trying to keep covered when you have a chronic illness. It's a nice safety net, but it is certainly not easy, not inexpensive, and not sustainable, because if your employer is small enough, they don't even have to give it to you. So it's for larger employer programs that can provide COBRA coverage if you have a separation of service, but smaller companies aren't required to do so. So good step, again, a Band-Aid, but we're starting to see some Band-Aids here. We're starting to see the law saying it's not enough. How do we fix it? And we start layering things. So we've now got Hatch-Waxman. Now we've got some generic drugs that are coming to market, which, by the way, those laws were set in 84. We've got a lot more drugs that are generic now than we did then. Maybe it's time to revisit some of the questions and policies that we set in 84. 85, we've got COBRA, and then we've got HIPAA. Jen, what is HIPAA really?
It's not a hippopotamus, guys. And it's very funny because for the first couple of years that HIPAA came out and there would be lectures about it, they'd always put a hippopotamus and then put an X through it and say, that's not what this is. Really, what started to occur was in the mid-90s, we started to understand genetics more. And we started to map the human genome and things of that nature. And what started to happen with that and other things was people became fearful that healthcare information and genetics would be used against people to get insurance. How many of us were worried that when we got diagnosed, with HCM or other diseases were afraid we wouldn't get health insurance, we wouldn't get a job, things of that nature. Also, the other part that was the impetus for this was, interestingly, was the electronic medical record. Because the mid-90s is when the electronic medical record, when we went from paper files in the doctor's office. I used to have at the end of my day a pile like this to write it out, to in 1996 when I started to do some work with Northwestern Medical Center in Chicago, and they were starting to put Epic in. And so again, there was fear how medical information, our personal medical information, would be used against us. And the government came out with some regulation from legislation called HIPAA. And HIPAA says that your health information cannot be used against you, and in fact cannot be shared unless it is under certain things. So if it's for your treatment, your information can be shared. If it's for operations, and I don't mean like medical operations cutting people open, but the operations of medical sort of things, billing, those sorts of things, HIPAA, privacy information can be shared. So that became a law that really, again, started to say, what can you do, what can't you do, and was, like COBRA, a protection. Sometimes it's used as a barrier to sharing data. And I'll hear, I can't give this information because it's a HIPAA violation. Truth, it's not. So it's sometimes used as a barrier, but really it was used initially as foundational support, very much like COBRA.
A lot of people think it's something that it is not. You still have access. It also allowed access to your own medical records.
Correct.
And portability of that information, and really put patients more in control. I would say from a regulatory process, if somebody does have a breach of health information, the pathway to restitution is not in the favor of the patient. The Division of Civil Rights is supposed to adjudicate all of these cases. Maybe in a future episode, we'll show you how many cases have been filed and how many people have actually been held accountable for bad actors. We've got problems there, but there are areas that we can work on understanding and then figuring out how to make it more functional today. So we'll be talking more about HIPAA in the future.
The conversation continues, but first, this quick break. We know life with HCM can feel complicated, and sometimes it's hard to know where to begin. The good news is we do. It starts with an intake call with our staff, where we listen and learn about your concerns. From there, we help connect you with our navigation team, who can answer questions about your condition and help you prepare for conversations with your HCM specialist. Intake and navigation help you make the most of every appointment. Learn more about our intake and navigation services at 4hcm.org. Once again, here's host Lisa Salberg.
1997 comes in, and Medicare Advantage. Love naming, right? So Jan, what is Medicare Advantage, and where did this terminology come from, and what's it really mean?
Okay, so Medicare Advantage, taking one step back for a moment, and that is, what did Medicare cover? What did traditional Medicare from 1965, Lyndon Johnson signing it, cover? Again, it was more of a major medical sort of situation. Didn't cover any prevention, didn't cover any wellness. It covered Medicare. Traditional Medicare covered sick care, if you will, for lack of a better term. 1997, after having 10 plus years of health maintenance organizations, it was realized, and by the way, people living by this point over 10 years average lifestyle, average length of life more than when in 1965, when Medicare came into play. It was understood that preventative care decreases the cost of Medicare because Medicare costs were going up way, way, way up. We're going way, way, way up. And they needed to have some control. And what they thought the control was, let's keep people from having those heart attacks. Let's keep people from having those strokes. Let's keep people from having COPD and pulmonary problems. And so Medicare Advantage became the preventative health care, broader coverage of Medicare in order to help keep people healthy and to not spend as much money in Medicare. Because before Medicare Advantage, you didn't have, today you have Medicare, you have the supplemental insurance to Medicare, which gives you many of the things that Medicare Advantage does. And then you had Medicare Advantage. And this really, again, was broadening the benefit in order to attempt to control the costs, which were skyrocketing at the time.
And this is where we are going to pause for the day. We are going to come back at a later podcast I'm going to pull my screen down here so we can just have a bit of a conversation. I just bought a new mouse, and this mouse and I don't want to cooperate. So we're setting up a foundation here, and we want to start to engage with the community in the coming weeks and months on understanding the foundational issues that we're dealing with healthcare access, and then figuring out what pathways may be available to bring about change in a positive way. Just handing people a check to pay for a policy isn't going to solve the problem. We have foundational problems that need to be solved. We are all human. We will be injured or get illness at some point in our existence as a human, and then we will die. And we have to manage our bodies and our health care in a logical way. And I'm hoping that over the next weeks, months, and year, we can have this conversation, and that the viewers here will bring in other viewers and will lean into the conversation and start thinking about healthcare as more of a system that we, as people living in a society, that we need to have conversations about how to fix it. It's not working for us all. It's working for some. And the foundation is actually pretty solid. And we have other countries that we can learn from as well. I don't believe that there's a perfect health system in the world, but I think that there are really good ideas that other people are utilizing throughout the world and that we might benefit from. So as we deconstruct healthcare, we might be bringing in concepts from other countries, from other cultures, from utilization of technology. There's a bunch of things we're going to start talking about. So this is the 101 class. This is the foundational class, which I'm going to have everybody come back and watch and listen to if they want to be part of this long-term conversation on how are we going to make things better. Jan, we're starting to unravel the basics. Where do you think the bumps lie in the road that have already been laid, and where have we set things up that maybe we didn't anticipate they'd go where they went? Can you identify a pivot point at this point, or aren't we there yet?
I think there are bumps in the road, or assumptions that were made, or changes in what has happened. You know, we talk about and I'm going to use two examples, medications. When these things all started with medications, there were 50 medications that were used across the board in 1985. Okay? That's all that was out there.
Wow.
The first time I prescribed Augmentin to a patient, to a parent, to a child, a parent called me back and yelled at me because it was $50 out of pocket and amoxicillin had been $10. But the amoxicillin wasn't working. So we have many drugs, many more drugs. My parents paid for all of my health care till the late 60s, early 70s, because my father was in a small business. So we paid out of pocket. It's like going to get my car wash is not paid by insurance. So I think there's societal human assumptions about what we should be paying for, what insurance should be paying for. We didn't have the drugs. We didn't have the technology. You know, Lisa, when I got diagnosed, you said to me, it's a good time to have a bad disease. Mm-hmm. And I have used that quote hundreds of times. And by the way, we're one of many. I have a very dear friend who has stage 4 cancer right now. She's living a great life. Yeah. Because immunotherapy and other things are out there. The world of medicine has changed. Our world has changed. But I think that there are bumps along the way, tweaks along the way. You know, Truman wanted something, Johnson tweaked. You're going to hear tweaks as we talk about Affordable Care Act tweaks, which interestingly, most of us, and you talk about Democrats and Republicans, and there's so much blaming today. The Affordable Care Act was a Republican idea. A Democrat put it in, said, hey, Republican, that's a really good idea. It's Romney Care. Romney was a Republican. Great idea, but we know we have to make tweaks. So anything that in life is static, we know. When we start a recipe, how often do we tweak what we put in it? And I think that's the issue that comes. It's healthcare and finances are the most personal issues we have in life. Yeah. And so until we are living with it through our families, ourselves, most of us don't spend their lives being like myself, who has worked in every part of healthcare. And I disagree with every part of healthcare, and I agree with every part of healthcare because of those tweaks, Lisa. So I think having the conversation and being realistic. I've worked in 16 countries. I've gotten to see what they do. They have many of the same problems we do, and they do it differently. So, but learning from each other, whether it's talking about it or learning from other countries, is as we move forward, what we're going to have to do to be open to tweaking and open to conversation. Everybody, I don't care what religion, what culture, what Democrat, Republican, Libertarian, Socialist, Communist, any of that. Guess what? We all, as you started out the day saying, we all, if we don't need healthcare today, we will need it tomorrow.
You will be a patient one day. And we are
Take it from me, who is healthy.
Yes, you're now doctor patient, right? Because
right,
doctors
exactly.
get sick too, right? They get diseases. The great thing about where we are today, and you brought it up earlier, the Human Genome Act, or Project, not Act, the Human Genome Project, gave us the ability to truly perform precision medicine. Mm-hmm. We have a reality in front of us today that we can identify disease in advance. We can get in there before disease impacts the organ of choice for that disease. In our case, it's the heart. We have therapies that can get in front of disease and stop disability from ever occurring. And here's the magic sauce here. What do we all want? We want to live our one wild and precious life. We want to be healthy enough to do it. And if we build a system that supports us in getting a diagnosis and then having access to those cutting edge therapies at reasonable prices, we live a better life. We are more productive members of society. We don't go out on disability. We don't have bad outcomes like having a cardiac arrest and surviving with a brain injury because we didn't get the ICD in time. We can live better, higher quality lives and be more productive members of society if we have access to these life-saving treatments that we've all worked so hard to develop and make available. So how do we take what we know in our health system and what we want it to be, and how do we make that future a reality? Because we're not going backwards in healthcare. We're not going back to a day where things were done differently. We must build something for our future because healthcare delivery is going to be different 5-10 years down the road. So thank you, Jan, for joining us to build a foundation on which we can continue having conversations. And in our last moment here, Jean had a question or comment. She's turning 65 years old. She's worried the medications won't transfer to Medicare or that you'll need to fight for it. Well, here's some good news for you in HCM anyway. Most of the medications that are currently available are easier to get through Medicare sometimes than they are through private insurance. So you're in good shape. We now have an out-of-pocket maximum for Medicare patients of $2,000 for prescriptions per year. There's a way to blend that cost. It's a little complicated, but if you can't afford $2,000 at one shot, you work with your pharmacy for blending. We'll talk more about that in a future episode, but you're actually in good shape there, girl. So good luck to you. And congratulations on that milestone birthday. All right, Jan, we're going to come back at another time and talk more about this. We're going to bring some other people into the conversation. And I'm even reaching out to some social media influencer creator types who are working in the space as well. So you might be seeing some interesting people come join us for conversations on deconstructing healthcare. So I'm glad that you've enjoyed the videos. Please share it. If you find this informative, bring other people to the conversation and start getting your questions together for what you want to challenge us to discuss. Jan, you're out in California. I hope you get a great weather day out there. I don't have one here in Jersey.
Well, I am. I'm very lucky. And, keep positive, people. We're gonna slowly figure this out. It's not going to change overnight. But if we all work together on it, we'll figure it out.
Couldn't agree more. Thanks for joining us on Tales from the Heart. I'm going to go out and do another episode of Tales from the Heart. Jan, I'm letting somebody do something I've never had done before. We're turning the tables, and one of our ambassadors is going to interview me.
Oh, I can't wait to hear it.
We'll see how that one goes. We'll see if it makes the light of day. I'm sure it'll be fine. Thank you all for joining. Have a great day and a happy weekend.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.